On to our next speaker, Dr. Tanya Balakrishnan, who is the Chief Medical Officer at Arvind Eye Hospital, Madurai. And her topic for today's presentation is role of OCT in our glaucoma practice.
Good morning, everyone. I'd like to thank Dr. Nikhil Balakrishnan for giving me this opportunity. So let's quickly go through how to interpret a posterior segment OCT in glaucoma. So the key parameters have a color-coded scheme where green indicates a normal reading and red an abnormal. The RNFL thickness map is the actual thickness of the retinal nerve fiber layer, and it has an hourglass or a butterfly wing appearance in the colors of yellow and red. It helps to detect any asymmetry between the superior and the inferior sectors, and also diagnoses an early peripheral defect, which is noted as a blue notch in the red and yellow sectors. The neuroretinal thickness plot evaluates the neuroretinal thickness, which is measured from the extremities of the Brooks membrane, and it helps to look for an extensive notch. The RNFL deviation map, there is no color overlay for the normal thickness, but when the thickness goes below 5 percentile, it shows up as a yellow patch, and anything lesser than 1 percentile is shown in red. The RNFL thickness T is in plot. In normal eyes, it has a double hump configuration, and there's a color coding in which white is the thickest, green areas are the middle values, and red is in outside normal range. The RNFL quadrants are pie graphs which summarize the RNFL thickness T is in plots. Coming to the OCT macular reports, the thickness map again shows the actual thickness of the ganglion cell layer and the inner plexiform layer. The deviation map again has no color overlay, and any thickness which is less than 1 to 5% is shown in yellow, and anything less than 1 is shown in red. The sector maps are divided into 3 equally sized pie-shaped sectors in the superior and inferior regions. There's a thickness table which gives us all the average and the minimum ganglion cell layer and inner plexiform layer thickness. The horizontal tomograph helps the interpreters know if the OCT is taken through the fovea, and any macular pathology seen on the OCT helps to correlate the pathologies in the OCT. Coming to clinical scenarios where we see how OCT has helped us in the diagnosis, progression, and treatment of glaucoma. So a 70-year-old male came to us to the glaucoma department with a best corrected vision of 6/9 in both the eyes. His pressures in the right eye were 32 millimeters of mercury, and the left eye 20 millimeters. The anterior segment of both the eyes showed a nuclear sclerosis grade 1. Both the fundus appeared relatively normal with a cup disc ratio of 0.6. The HFA of both the eyes was within the normal limits. So what should we do now? Only the pressures are raised with no significant changes in the disc or the HFA. But taking an OCT, we can see that there is a thinning noted in the RNFL thickness map and in the deviation map. The key parameters show the values in yellow, which shows that there is a borderline change. And in the T-isn't map, we can see a slight dip in the inferior quadrant. Corresponding OCT macular reports also show thinning in the inferior region. So the case 1 was an early glaucomatous damage, which can be also called as a pre-perimetric glaucoma, when there is still no functional damage on the vision field tests, but a high IOP and an early glaucomatous change was noted on the OCT. So starting an anti-glaucoma medication at this stage is advisable to prevent any further damage in the right eye. Coming to case 2, a 52-year-old female came to us with the best corrected vision of 6/6 in both the eyes. The left eye showed PXF material in the pupillary margin. The left eye fundus examination showed a 0.6 cupping with the inferior thinning of the neuroretinal rim. She was diagnosed with left eye pseudoexfoliation glaucoma and started on eye drop Stimulol BD and her pressures were maintained at 20 millimeters of mercury by using the drops. The baseline OCT, HFA showed a superior arcuate scotoma, but comparing the HFA at 9 months, we see there is a very small, non-significant change in the HFA. So do we continue the same medication or do we need to step up treatment? A GP analysis on the OCT shows that there is more thinning in the inferior sector, and also the thickness of the inferior sector plotted shows there is progression and increase of thinning in the inferior section. So this is a case of a moderate glaucoma with disc changes and a vision field defect, which corresponds to the OCT findings. But on a subsequent follow-up at 9 months, there was no specific change noted at the HFA. But since there was progression noted in the OCT, it is imperative to step up treatment to prevent further damage. Coming to the third case, a 40-year-old man with a best corrected vision of 6/6 in both the eyes and an anterior segment within normal limits, with the fundus examination showing a cup disc ratio of 0.5 with a slightly suspicious superior rim thinning. The HFA of his eye was normal, and the right eye pressures were noted as 17 millimeters per mercury. But on doing an OCT pachymeter, we saw that the CCT, the central corneal thickness, was 445. So the corrected IOP is actually 24 millimeters per mercury. And the OCT also showed corresponding thinning of the superior sector, as noted in the RNFL thickness map and the quadrant map. So this case was a case of a slightly suspicious disc with an IOP within the normal limits, but no functional damage noted. So the early diagnosis of glaucoma could easily be missed in such a case, but with the help of the OCT confirming the thinning of the RNFL and the OCT pachymeter giving us a clue of a falsely low IOP due to a thin cornea, we could start treatment early for the patient. Coming to the last case, a 35-year-old female with a best corrected vision of 6/6 in both the eyes had an IOP of 24 millimeters per mercury in both the eyes. Her anterior segment and posterior segment were within normal limits with a cup disc ratio of 0.3 in both the eyes. Her HFAs were within normal limits, so was the OCT. So why were the pressures actually high? On doing a pachymeter, we saw that a central corneal thickness was 599 in both the eyes. So the corrected IOP was actually only 20 millimeters per mercury. So in this case, although there was a raised IOP, there was no glaucomatous change or a field change. And since the pachymeter showed that the corneas were slightly thicker, it was just a falsely high IOP measurement. And this case was an ocular hypertension case, and we did not need to start treatment immediately and just follow up the patient.